Hello, everyone. Thank you for joining another episode of Rainfall Health Team Podcast Series. My name is Eddie Qureshi. I'm the founder and CEO of Rainfall Health. We are an AI-enabled accountability and accessibility software to maximize Medicare reimbursement. For the team model, we are helping executives of mandated hospitals and systems go from stressed to successful and overwhelmed to over the moon. If you're interested in finding out how your facility may be impacted by this requirement, reach out to us and one of our experts would be happy to help. Today, we're joined by Dr. Rob Bart, a healthcare leader whose career has spanned health systems and coasts. And he's also a member of the inaugural RAIN Advisory Committee responding to the team model. Dr. Bart, welcome to Rainfall Health, and please tell us a little bit about yourself and your background.
Thank you, Eddie, and thank you for having me here. So, as Eddie mentioned, I'm currently the Chief Medical Information Officer at UPMC. I've been here just under 8 years, new to Pittsburgh in Pennsylvania, had spent the prior 20 years in Los Angeles, most recently as the Chief Medical Information Officer for the Los Angeles County Department of Health. Clinically, I'm a pediatric intensivist, so I've spent most of my clinical work inside of children's hospitals. I think Eddie and I got acquainted in the last couple of years, have had a number of substantive conversations, which I think resulted in me being asked to join the advisory committee here for Rainfall Health. I've enjoyed my time so far, and look forward to future interactions with Eddie and Rainfall going forward.
Thank you, Dr. Bart. As you were mentioning, the thing I feel like that really brought us together were our conversations about, especially your passion about increasing access to quality care and also making it sustainable over time. So relevant to especially your time at LA Health Systems, but also, in any major health system around the country. So, bringing it to team, which is such an impactful model that's coming out right now, what do you think is the potential for team to be the next generation for achieving those goals around outcomes and aligning those between health systems and the patients?
I think a couple things before we get to team. I think we need to think about why we need a new model and how we've sort of gotten to where we are today. You sort of tapped on or pulled on a thread related to my time in Los Angeles County Department of Health, and I think my time there, it was predominantly focused on meeting the healthcare needs of the uninsured and the underinsured in Los Angeles County. And it really was formative on me and what healthcare can and should do. And there's unfortunately a lot of fragmentation in healthcare. A lot of that, it's hard to know who's at fault, right? But clearly the models that we have are relatively challenging to navigate. And that's true whether you have commercial insurance or government insurance or don't have insurance. And I think when you start thinking about how do we improve healthcare, decreasing fragmentation and decreasing the navigation challenge for the consumer who becomes the patient is ultimately with the direction that we want to really move everything in the U.S. healthcare system. And I think to that, CMS has come up and developed this team model, right, which is transforming the episode accountability model of care. That's what TEAM stands for. And it's around the fact that healthcare is predominantly episodic. Even myself, who I have had some, advanced healthcare needs over the years. But if I'm otherwise feeling well, I'm not doing anything. And so it's all these episodes of care. And it's how do we bridge that together? And I think the focus here in the team model is how do we bridge surgical events together in what they're doing? And frequently people think I go in, I get the surgery, and then I leave. But that probably works for 90% of the people. 95% of the people, because most of the surgical procedures are without any challenges and are successful and do well. But there are some people who have complications or they have comorbidities which means that their surgery is a little bit more risk because their usual state of health has some chronic disease to it. And so as you're starting to think about this, how do you incorporate all that surrounds a surgical procedure event, not just the surgery, but the preoperative period as well as the postoperative period? Preoperatively, so you're getting that patient to the best point of health to tolerate and do well with the surgery, and then postoperative, so that you're recovering them to their best degree of health possible in the postoperative state. And how do you sort of create brackets around all of that and create a unified care process as opposed to the episodes that would typically be fragmented, particularly and potentially between the surgeon and the primary care physicians? How do you create that connection and the collaboration that's needed in that transition of care so that patient and that person actually feels like they're really embraced by the healthcare system? I think that's really what CMS is trying to do with this model. That's really the functional aspects. It doesn't incorporate all of there are financial reimbursement compensation aspects that are related to underpinning of it. But I think that is the piece of it that's the most important.
No, thanks for framing that so well. And this actually brings up a theme I feel like that's been as part of these conversations now that we're on a third one with you, which is this model. It is impactful, but if you come back down to the basics, the fundamentals of why it exists, it's designed to make healthcare more cohesive. So that is a goal I think all the executives who listen to this series can get behind. A lot of the operators
Absolutely.
can get behind. So, for especially your role, I want to pose it less from the CMS side and say, for the systems and hospitals, the facilities that are actually impacted, this theme that comes up, and I want to ask you about it, which is, what are the challenges, but also the opportunities with this model?
I think the challenges are basic communication. That's one of them, right? That healthcare requires clinicians in 2025. They tend to be so busy with their practice, whether they're a primary care or whether they're a surgeon, and you need tools to help and create the collaborative environment to connect them so that the communication is easy. And so the transition of care back and forth between whether it's just those two or it also includes the hospital, so that you can ensure an ease of communication and the patient feels very comfortable and trusts that when I go from my surgeon to my primary care and back and forth, that they're both up to date on what my current state is, right? And so I think part of the challenge is basic structure of collaboration and easing safe communication about the patient and their condition as they move through their care journey. I think that's one piece. I think the opportunity is we want to be able to return a patient who gets a procedure back to their usual previous state of health, or in some cases, let's say that it's an orthopedic procedure where they're having a hip or knee replaced. You would hope that they would actually attain even a higher degree of health afterwards, and certainly mobility. And the only way to really that's like the ideal outcome and the opportunity. And I think that's what the focus needs to be on. Is how do we ease the burden of the transfer of information, the communication through the care pathway, so that we can optimize the outcome for the patient, and also I think decrease some of the friction in the healthcare delivery that patients receive. I alluded to, some of the health challenges I've had over the years, and I have had surgery, and I frequently think of myself, if this is challenging for me, who is a physician working inside of a healthcare system and understands how to navigate it, right? How is it for someone who walks in off the street and doesn't have this background for them to navigate it? I think it's a challenge. This is a challenge we're solving, And I think this model is one that sort of aligns what we would love to deliver in US healthcare as the ideal outcome for the patient with how we need to improve the approaches in coordination and communication of care so that we do achieve that. And then it aligns the incentive of the compensation and reimbursement if you achieve those outcomes, right? So I think that that's where the opportunity is for the healthcare systems. Why go do it? Better patient satisfaction, improve patient outcome, while at the same time, you've actually improved your processes and care delivery, resulting in compensation from the government.
Such a great way to synthesize all these ways, all the way from the clinical to the financial and all the complexity that it takes. Well, now that we have you here from as a CMIO, let me ask you specifically, what are can you provide us with some insights from your experience on how technical strategy can support the quality and the regulatory challenges specifically for models like TEAM?
Yeah, so I think there's probably two separate sets of circumstances. So at UPMC, where I am, if the patient's receiving their care completely by our employed clinicians, so employed primary care physician, employed surgeon, there's a lot less friction because they will be on one electronic health record platform, and so there's no interoperability required. They can exchange information freely, and when the surgeon and the primary care physician open the patient's record, they're looking at the exact same record. But that is not the case all the time. We're frequently working with community physicians, both at the surgeon and at the primary care side, who have their own electronic health record within their office practices. And that's where I think care coordination, if it's not thoughtful about how you interoperate, how you exchange information, how you connect, EHRA to health system EHRB, then make that digital exchange, that's where the friction comes in. And that friction translates into a hassle for the clinicians in their offices, but ultimately it translates into a hassle and potentially disrupted care for that patient. And I think there are better interoperable tools. They're allowing more digital communication to make sure the information is not just accurate, but it's timely. It's frequently the timeliness of the information that's one of the key ingredients here. And that's one of the things that we're really focused on here at UPMC, and I know other healthcare systems are. But and those are the types of tools I think that people need to really be able to excel and execute the team model well.
Those are some great points, especially the timeliness, right? Even the model specifically lays out the post 30 days post procedure as a time frame, because that is when there's a lot of handoffs, there's a lot of that follow-up care that needs to happen. And from the financial side, as you alluded to as well, in some of these procedures, the cost, over 50% of some of the cost is actually happening post-procedure, which is not something that we always tend to be confronted with.
Absolutely.
So now, not to scare our listeners too much, which is the first deadline for the team model specifically is only 6 months away from when we're recording this. What are the challenges facing health systems to implement team and other such models in such a quick time frame? 6 months.
It is a big challenge, Eddie, to be quite honest. Now, some people would say, well, you have 6 months, you have 180 days to get this done. But we all have multiple ongoing projects that are occurring in our healthcare systems right now. And there are multiple avenues that we're all trying to solve: access to care. There are multiple pressures, whether it's from government pay or commercial pay, that we're all sort of managing and trying to juggle and balance. And so as much as I'm an advocate of some of the new models like the team model that CMS is putting forward, I'm not sure that every healthcare system can actually undertake it unto themselves. They may not have the tools and the ability. I think UPMC, being a large integrated delivery network with multiple hospitals, and only a portion of our hospitals are impacted by this model. I think we do have resources that better enable us to be able to undertake some of what needs to occur to improve care coordination and care communication, which are really, I think, two of the foundational tenets of the team model. But when I look at sort of the list of hospitals that are impacted from a UPMC perspective, if I think about what if they were standalone facilities, it might be challenging for independent facilities to actually be able to sort of turn on a dime, make the investment, and be able to do this successfully. I believe that many of these organizations and facilities, they're going to need partners in this space to be able to do it in this time frame. And then it's not just standing it up. It's the ongoing monitoring and maintenance and having the right tools to make sure you're doing that, not just for the first patient and on the first day, but you're doing it for all of the patients who have to go through this program from the facility or facilities that you're responsible for. And I think that's where they're going to need partnership, right? And they're going to need, and it may not even be partnership in technology. It just may be partnership in guidance and structure. How do you successfully create a program to do this? And and that's one of the things, I think out of our conversations, Eddie, when we started having these conversations and some of the aligned thinking that we had, sort of resulted in why you and I are chatting today, why I joined the advisory committee for Rainfall Health, is I think that direction of, can you help sort of have some of the strategic conversations that you need to be the foundational steps to actually be able to implement a program so that you can not only take on team, but you don't have a choice. If your facility's in that bucket, you have to go do this. So, and so I think, as I think about it, it's going to be internally at UPMC, it's internally some of the technology and tools we have. But even with our resources, we will be looking to entities such as Rainfall Health for some guidance and, checking to make sure, are we thinking about this the right way? And what are some of the other things that we need to consider? I think about, not related to a reimbursement model, but, another big program we had to do a few years ago was related to information blocking. And we did frequent checks with other healthcare systems and other entities on, how are you interpreting this? This is how we're interpreting it. Because one of the I think frequent challenges when the government hands you a new program is they don't really give you, a step-by-step, this is how you go do it. They sort of tell you, this is what the program is, this is what the outcome that's expected, this is what's going to happen to you as a healthcare system, but you're left with connecting the dots on how to build it and how to execute it within your healthcare system. And information blocking was like that, and I think the team program is somewhat like that in the structure. I know that you have had the opportunity to talk to hospitals, other healthcare systems, and I would ask you actually, Eddie, what are some of the things that you've seen from your vantage point at Rainfall Health?
Yeah, absolutely. I think there's so much truth to what you're saying, right? Even though everybody's can be reading the same piece of regulatory requirements, but because this is only a fragment, like you said, of the things that are being tracked by each system, and then each system is facing different challenges around coordination of care, resources, geography, and their makeup of their patients, it's going to be difficult to figure out a standardized way to do this. In some ways, we see fragmentation actually increase because everybody finds their own bespoke way to approach these different models. So from our side, part of the reason why we have folks like you, Secretary Shulkin, Timothy Stroh, these amazing folks who joined this advisory committee, and all the other conversations we're having with leading health systems all the way to standalone facilities in rural America who are on this model, what we're really noticing is, how do you approach it in a more standardized way? How do we actually start using this as an opportunity to take down some of the differences that have been built over time and align in a more standardized way? And that's what's interesting for especially systems like UPMC, which might have multiple facilities on the model, not all of them, but multiple, that having a standardized approach makes sense because that'll pay dividends over the 5 years of just this model alone. The announcements that CMMI has already made that this model is set to expand both within more procedures, additional Medicare beneficiaries, as well as Medicaid beneficiaries over time. So taking that investment ahead of time could be huge to making sure that we're continuing to align rather than creating separate solutions that won't achieve the test of scale or time, which we've done as healthcare, US healthcare in the past. But this is a potential time to realign. And I think there's a lot of momentum behind that we're seeing. So a lot of opportunity for sure.
Yeah, I completely agree with you. I think that I've had the fortune of my career working in multiple healthcare systems, and for the most part, the same problem tends to be solved very differently in each of the healthcare systems that I've been in, right? And that speaks to the innovation and the desire of each healthcare system to go and achieve and do what they believe is best. But it also speaks to the fact that there's a lack of healthcare at the broader U.S. healthcare segment. There's a lack of standardization and of sort of achieving the collective goal. So I think to your point, if we can achieve better collaboration across healthcare systems and collectively define this is how we think is the best way to go achieve it, I think it could help everybody achieve better what they're trying to do, as opposed to, each one trying to figure out how to create a, better way to slice bread or a better mousetrap.
I couldn't agree more. And as you know, that's what we're trying to do here at Rainfall Health. And thank you for the advice and the insights that you and the rest of the committee bring to making this a more standard and scalable model. This is a fantastic conversation. Thank you so much for being a part of it. And just to summarize some of the things we talked about, which is there are a lot of challenges ahead. It is a quick time frame for systems that have been around for 100 years to move at a 6-month timeline can be challenging. But there is also this push towards a new way to deliver care in a more aligned fashion, and even between systems and different care delivery organizations, that this model itself just mandates post-procedure, post-acute care that might be delivered in the community to realign and have a financial incentive to do so as well. It's a challenging piece, but we also are here as Rainfall Health to be a resource for folks. And it's a challenging model, but hopefully we can make it a little bit easier to follow and operationalize those learnings. Thank you so much, Dr. Bart, for being here today. We appreciate all your insights.
Thank you, Eddie. I enjoyed the conversation with you.